Hi, very good morning. I'm Dr. Janak Patel. I'm MD General Physician. Today we'll be talking on one of the another interesting topic in cardiovascular system among valvular heart disease, that is mitral regurgitation. So meaning is very simple. Regurgitation means blood which is supposed to flow from left ventricle into aorta during ventricular systole, but because of incomplete closure of mitral valve, blood from LV will flow to both into aorta and back into left atrium. This backflow into left atrium, we label that as mitral regurgitation. So it's very clear that when valve does not close during ventricular systole, blood from left ventricle will regurgitate back into left atrium during ventricular systole, and this is called regurgitation, or some use word incompetence or insufficiency. But the last two words, that is incompetence and insufficiency, is almost outdated. Now the common terminology which is utilized is regurgitation. And depending upon the onset, either it is called acute or chronic. So there are some terminology which are being utilized. One, on the ground of severity, mild, moderate and severe. Second, on the ground of etiology, the commonest cause being rheumatic fever, ischemic heart disease, traumatic, infective endocarditis, dilated cardiomyopathy, post-traumatic, post-surgical, etc. Depending upon which structure is being involved, valvular, involvement of ring, papillary muscle, chorda tendina, or LV dilatation. Onset wise, acute, chronic. Then there is also one term which is utilized is compensated, where the signs of failure is not there, and decompensated when you start getting signs of left ventricular failure, that is called decompensated. Again, another word, etiology wise, it is divided into two big groups, congenital and acquired. In congenital, mitral valve prolapse and endocardial cushion defects. And among acquired, rheumatic fever, ischemic heart disease, traumatic, infective endocarditis, dilated cardiomyopathy which can be acquired. Also in congenital also there are congenital conditions which produce dilated cardiomyopathy, etc. So these are some of the terminology which are being commonly utilized in everyday practice. So commonly it is divided into acute and chronic. Chronic is divided into two common groups, compensated and decompensated. By and large, acute will results into sudden onset of overload on LV, which will end up with acute left ventricular failure. So usually in an acute, it is always decompensated. So this is one way of putting together. Another way is congenital and acquired group. Among congenital group, mitral valve prolapse, which is very common in younger age group, predominantly in female. On auscultation, you get a click, or there is a click followed by a murmur. There is a thin leaflet with systolic displacement which can be seen on echocardiography. It is called as a systolic anterior motion called SAM. SAM, SAM. S for systolic, A for anterior, M for motion. Also, good number of times this mitral valve prolapse is also called SAM, associated with low blood pressure, orthostatic hypotension, palpitation. And invariably it has got a benign long-term course. So this is the most common cause in congenital. Another common is myxomatous mitral valve disease, which is between 40 to 70 years of age group, predominantly male. There is a thick valve, redundant valve leaflets. Mitral regurgitation can be seen on physical examination as well as echocardiography. And there is a progressive disease requiring invariably mitral valve surgery. There is a third group in congenital we call as a mitral valve prolapse secondary due to Marfan syndrome, hypertrophic cardiomyopathy, Ehlers-Danlos, and other connective tissue disorder. This is typical Ehlers-Danlos. You can see there is arachnodactyly, dilatation of root of aorta, pectus excavatum. This will be commonly seen in Marfan's. And you can have an abnormality even in cornea and iris. Chronic mitral regurgitation, very frequently you can see in a mitral valve prolapse. You can see here, this is normal movement of mitral valve. You can see this is having a little systolic anterior motion, and that's why it is also called as a SAM. And this is also called as mitral valve prolapse or floppy mitral valve. Now, if we go through the etiology, in acute, the most common cause is ischemic heart disease, and among ischemic heart disease, acute myocardial infarction. Also, you can come across in ischemic heart disease chorda tendini rupture, papillary muscle rupture, or papillary muscle dysfunction. Infective endocarditis can produce destruction of the valvular structure, destruction of a chorda tendini, etc. So, in infective endocarditis, you can get mitral regurgitation, acute MR, because of chorda tendini rupture or because of papillary muscle rupture secondary due to infective endocarditis, or even because of a destruction of a valvular structure. You can get damage to valvular structure during procedures or during surgery. So that's why the two words commonly utilized, post-surgical or post-traumatic. During some surgical procedure like mitral valve replacement, or during right heart catheterization, or during pacing, or during CRT, etc. The catheter can produce a damage to the valvular structure and can end up with an acute MR. Sorry, it will be left heart catheterization, not right heart catheterization. Sorry. So this will be the conditions which can produce acute. In acute rheumatic fever, usually mitral valve is involved and you can have an acute MR. And that particular can also end up with acute left ventricular failure during acute rheumatic fever, which is producing acute endocarditis. As far as chronic is concerned, the commonest cause which is among acquired group is chronic rheumatic heart disease, or it is also labeled as chronic rheumatic valvular heart disease. In congenital variety, mitral valve prolapse, there are many other names for mitral valve prolapse, SAM, floppy mitral valve, Barlow syndromes, etc. Even ischemic heart disease, infective endocarditis can produce a chronic onset. SLE, rheumatoid arthritis, mitral valve calcification can be chronic in etiology. Dilated cardiomyopathy, which can be acquired or can be congenital. Among acquired, it can be alcohol, it can be ischemic, etc. And any condition which results in a left ventricular dilatation can also end up in a stretching of the ring will produce mitral regurgitation. In congenital, you can have a rarely involvement of endocardial cushion which can end up with MR along with ASD, VSD. So we already mentioned in acute the most common cause is infective endocarditis, acute MI resulting into rupture of papillary muscle or chorda tendini rupture. As far as chronic is concerned, mitral valve prolapse, rheumatic fever, healed endocarditis, annular calcification, hypertrophic cardiomyopathy, obstructive cardiomyopathy with SAM, or because of AV canal defects or endocardial cushion defects, ischemic dilated cardiomyopathy or dilated cardiomyopathy, any one of these common causes. Depending upon which portion is being involved, you can divide into valvular, leaflets variety, chorda tendini, annular calcification or infective endocarditis damage, papillary muscle rupture or papillary muscle involvement, LV dilatation, functional regurgitation, traumatic etiology, and post-surgical. And in that we have mentioned some of the common causes. At your leisure time, you can go through some of the common which usually in a mitral valve is rheumatic, infective endocarditis, congenital defects, mitral valve prolapse, chorda tendini, most common is infective endocarditis and what we called as acute myocardial infarction. Annulus calcification and abscess secondary due to infective endocarditis is common. Papillary muscle, most common is myocardial infarction, ischemic heart disease, infective endocarditis. LV dilatation, classical example, dilated cardiomyopathy. Or maybe say person is having AR which produces a big LV dilatation. There is a ring dilatation and that can end up with mitral regurgitation also simultaneously. And traumatic etiology we already mentioned, left heart catheterization and post-surgical balloon valvoplasty or following a mitral valve replacement which can be leaking mitral valve. You can divide into primary and secondary. Primary is organic, classical example rheumatic endocarditis, flail prolapse mitral valve, myxomatous degeneration. As far as functional is concerned, dilated cardiomyopathy and acute MI which produces papillary muscle rupture or chorda tendini rupture. This is typically being described mitral valve prolapse or floppy mitral valve or SAM or even Barlow syndromes common. And the commonest etiology can be congenital or can be degenerative myxomatous changes. Also you can get in Marfan syndrome, Ehlers-Danlos, etc. If you look at the percentage, the mitral valve prolapse will be accounting for 20 to 70% of the cases. Ischemic heart disease from 13 to 40% of the cases, this is second common cause, and third common cause is rheumatic heart disease, that is 3 to 40%, while infective endocarditis is less in case of 10 to 12%. So a big number of group is rheumatic. This is mitral valve prolapse which is accounting for almost 50%, ischemic heart disease is only 10%, and endocarditis is very less, 3%. This is one series. This is showing you destruction of a mitral valve secondary to infective endocarditis, and this is floppy mitral valve. Mitral valve prolapse. This is showing you damage to the papillary muscle, ischemic heart disease, damage to myocardium, damage to papillary muscle, chorda tendini, and can produce acute MR. This is rheumatic involvement of a mitral valve. This is showing you normal mitral valve, which is thin, papery, and absolutely transparent. And you can see that there is a lot of infective material being deposited on mitral valve. Acute rheumatic fever. Now we'll divide into two big groups: acute regurgitation, chronic regurgitation. Now in acute regurgitation, if I go through this, because of acute regurgitation, blood from LV will regurgitate back into LA. A small quantity of blood will enter into aorta. And as there is a very small quantity which is entering into aorta, the cardiac output is reduced. Pulse volume will be low volume. And there may be little amount of hypotension. And if it is very massive, severe variety, you can have even hypotension and shock stage. All the blood which is entering into LA regurgitate back from LV into LA will come back to LV during ventricular diastole. So left ventricle will have a volume overload. And because of volume overload, now ventricle will try to compensate by dilatation plus hypertrophy. But being an acute, the left ventricle doesn't get a chance to undergo dilatation as well as hypertrophy. So there is an increased sudden volume load, and because of increased sudden volume load, the left ventricle will not be able to compensate, and as it is not able to compensate, the left ventricle will undergo acute failure, which will increase LA pressure, pulmonary venous pressure, and acute pulmonary edema, and that will give rise to pulmonary congestion, orthopnea, blood-stained frothy sputum, central cyanosis, basal crackles, central plus peripheral cyanosis because of marked decrease in cardiac output. So we call mixed cyanosis, etc. This will be common in an acute variety. So in an acute variety, because of backflow, LA volume is increased, LA pressure is increased, pulmonary congestion. Secondary to pulmonary congestion, now you will start developing acute pulmonary edema. Now decrease forward systolic volume. There is a compensatory heart rate increase, decrease in cardiac output, and person can have a symptom sign suggestive of a shock stage. And because of decreased cardiac output, vascular resistance, RAS system activation, that will also further produce cold clammy extremities. So this will be the entire picture which will be coming across. As far as sudden large volume overload on LA and LV, the left ventricle doesn't get a chance to undergo compensation like hypertrophy, as well as LA also doesn't get a chance to compensate. And that's the condition where you may not have a big LA and big LV, and person is having a symptom signs of acute left ventricular failure. So that will be very, very typical in acute variety. So this is that typical. But if a person is having a chronic, because of regurgitation, now what happens? The blood which goes back to LA, left atrial volume is increased, so it undergoes dilatation. Compensatory mechanism, hypertrophy, so LA is dilated plus hypertrophy. Because of overstretching of LA, that is atrial flutter fibrillation, left atrial thrombus formation, thromboembolism. Secondary to increase in the regurgitation volume, all that blood is going to come back to LV. LV will have a large volume. Initially, there is increase in cardiac output because volume is more. So the blood coming out will try to maintain cardiac output. Left ventricle will undergo dilatation plus hypertrophy. Now simultaneously, because of increase blood in LA, there is an increase in LA pressure, pulmonary congestion, pulmonary venous pressure elevation, pulmonary hypertension. Secondary to pulmonary hypertension, these are all the changes which are chronically occurring. So secondary to pulmonary hypertension, now RV pressure overload. Right ventricle has to do more work in ejecting blood into pulmonary artery. So it will have an increase after load. Secondary to that, right ventricle will start undergoing hypertrophy. RV pressure will be elevated, which will have elevation of RA pressure. Increased pressure in superior vena cava, inferior vena cava, and you will have all the signs suggestive of congestive cardiac failure in the form of a jugular venous pressure elevation. Jugular vein will be dilated, hepatosplenomegaly, hepatic congestion, tricuspid regurgitation. RA will also start getting enlarged, RV hypertrophy. So this will end up with right side heart failure. So here you will have a big LA, big LV, right ventricular hypertrophy, right atrial enlargement, and symptom signs of congestive cardiac failure. Secondary to very big enlargement of LA, there will be pressure effect on the surrounding structures like recurrent laryngeal nerve. Compression of a recurrent laryngeal nerve will produce left side vocal cord palsy, resulting into hoarseness of voice. It is also called as Ortner syndrome. Left main bronchus will be also compressed. You will have cough, hemoptysis, and sometimes it can end up with total collapse of the left lung, dyspnea. Compression of a esophagus will produce dysphagia. So these are the compressive symptoms which can appear because of a big LA. On a damaged valve, you can have an infective endocarditis, and secondary to that, you will have a symptom signs of infective endocarditis, and that can dislodge, producing systemic embolization, which will be infected material resulting into brain abscess, pyogenic meningitis, Osler's sign, Janeway's node, glomerulonephritis, Roth spot, splinter hemorrhages, etc. But LA thrombus, when it gets dislodged, it is pure simple blood clot material. So it will not end up with any infective pathophysiology. It can end up with systemic embolization, producing stroke, splenic infarcts, or you can have a thromboembolism in any systemic circulation. So this will happen in a mild MR, which are usually chronic in etiology, onset-wise chronic in etiology. So this will be typical in a chronic variety. I have discussed everything. These are the slides. At your leisure time, you can go through. Whatever I have mentioned before is mentioned here. This is in a chronic. You will have a big LV, huge dilatation with hypertrophy. LA also very big with hypertrophy. RV will be hypertrophic but not much enlarged, and RA can be there. But left ventricle and LA will be dilated plus hypertrophy. Very, very typical. In a decompensated, now you will have also signs of what we call as a pulmonary congestion and pulmonary edema in a decompensated state. By and large, mitral valve prolapse can have a benign course. But in between, secondary to endocarditis, cauda tendini rupture, progressive regurgitation, you can have arrhythmias, thromboembolism, and even person can have a sudden cardiac death. Clinical symptom wise, person can present with SOB, shortness of breath, dyspnea, in left ventricular failure, orthopnea, PND. Because of decreased cardiac output, fatigue, because of atrial flutter fibrillation, palpitation. In a chronic and mild variety, right ventricular failure, which will produce pedal edema, which is pitting, JVP elevated, hepatosplenomegaly, ascites, HJR, hepatojugular reflux, JVP will be elevated, jugular venous will be distended. In a left ventricular failure, you will have orthopnea, PND, central cyanosis, basal crackles. That will be more common in in an acute rather than chronic. In a chronic, in a decompensated stage, you can have a symptom signs of mix, that is right ventricular failure with left ventricular failure signs. Secondary to pulmonary hypertension, you can have a chest pain, cough, and hemoptysis. Acute and severe variety, I have already told you, it will present as an acute left ventricular failure symptom signs, while chronic variety will present more commonly with the right ventricular failure signs. So at your leisure time, go through, these are all the symptom signs of an acute and severe mitral regurgitation, where you will get more of LV, left ventricular failure signs, and in a chronic, you will get more of right ventricular failure signs. So these are chronic mitral regurgitation findings I've already mentioned in pathophysiology. So roughly to take over that, pulse will be of a low volume, apex will be grossly downwards and outwards, huge cardiomegaly, there will be S3 on a LV, you will get a palpable thrill which will be systolic, first heart sound will be soft or absent, second heart sound you will have a P2 loud, there will be pansystolic murmur, loudest at apex, conducted to axilla, typical of chronic mitral regurgitation. So there will be a pansystolic murmur, hollow character, high pitch rumbling murmur. Some people describe as a hollow murmur or musical murmur, radiated to axilla and will change with respiration, Valsalva maneuver, or with position also. This is a minor difference between acute MR and chronic MR. At your leisure time, you can go through. We already mentioned in pathophysiology what is common in an acute MR and what is there in a chronic MR. These are hemodynamic findings which can be there when you do the hemodynamic study by cardiac catheterization. So these are the difference what you can come across in that, and echo findings. These are the ECG difference, heart size difference, systolic murmur, JVP, etc. Difference between acute and chronic. We already mentioned everything in a differential diagnosis. MR can occur at any age. It is common in male as well as female. Some diseases are more common in female, some diseases are more common in male. Mild variety will be by and large asymptomatic, but moderate to severe variety may be symptomatic. In mild to moderate variety, it will be a chronic onset, gradual onset, and it will usually end up with a right ventricular failure, while an acute variety are usually severe and they will end up with acute left ventricular failure. Palpitation is very commonly because of atrial flutter fibrillation. A person who has got a marked decrease in a cardiac output will have a pre-syncope, syncope, chest pain, and shortness of breath. This will be more common with an acute variety rather than a chronic variety. Atypical chest pain, palpitation, dyspnea, syncope is more common with acute variety. And also you can get in a mitral valve prolapse. Due to decrease in cardiac output, blood pressure may be little low. Person can have even orthostatic hypotension. And person can have a straight back syndrome. Chest pain, palpitation is most common, and auscultation. Because of floppy mitral valve, you can get a mid-systolic click followed by a murmur. And that is very characteristic of a mitral valve prolapse. And on echo, you can demonstrate SAM, systolic anterior motion of anterior mitral valve leaflet. On auscultation, you get a mid-systolic click followed by a systolic murmur, which is very frequently high-pitched, systolic, late systolic, crescendo, decrescendo murmur, which is good number of times described as a whooping or a honking murmur, and base heard at apex. Very frequently, the course is usually benign but may develop complication like endocarditis and can progress into an acute or chronic MR. Thromboembolisms are common, and secondarily there are atrial flutter fibrillation and occasionally ventricular arrhythmias are also common. This is a difference between mild, moderate and severe at your leisure time. If you are interested, you can go through. I am holding this slide for a while. You can see, go through that slide. These are the difference between mild, moderate and severe, differences. This is the difference in different hemodynamic studies. As far as investigation is concerned, chest X-ray will show you a very huge LV and very big LA. We call dilatation plus hypertrophy. So giant cardiomegaly, pulmonary congestion, which will be more common with chronic rather than acute. In an acute, usually you might have a mild cardiomegaly or even sometime a normal size heart with severe pulmonary congestion and symptom signs suggestive of acute pulmonary edema in chest X-ray in the form of bat wing appearance, curly A line, curly B line. As far as ECG is concerned, LVH is most common, LA. So LV and LA are usually enlarged. So you will have a ECG finding of LVH, P mitral, and if person is having atrial flutter fibrillation, you will not be able to identify P mitral. Echo will give you all idea regarding the size of LV, the hypertrophy of LV, LA size, LA hypertrophy, valvular structure, type of valve involvement, severity of valve involvement, presence of thrombus, LA thrombus, presence of infective endocarditis, any damage to the valve, other associated valvular structure involvement, etc. can be easily identified. And if you use a Doppler, you can differentiate pressure gradient across the mitral valve. Transesophageal echo may be occasionally required to find out changes in LV and LA. Angiography and MR combination or MRI angio is required to find out the amount of coronary perfusion and other findings. I've already mentioned regarding ECG, X-ray chest, echo, Doppler and cardiac catheterizations. So these are the ECG findings: LA enlargement, atrial flutter fibrillation, LV. RVH is more common in a chronic variety, where in 15% of the people you can get RVH. So combined hypertrophy will be seen in 5% of the people. In a chest X-ray, a huge LV and LA. LA is quite big, may produce even a double atrial shadow, and this will be very typical in a chronic and mild variety. Increased pulmonary vascular congestion and symptom signs of congestive heart failure. Calcification of a mitral valve may be seen in some of the cases. You can see here, this is a double atrial shadow, almost mitralization and very big cardiomegaly. Apex is downwards and outwards. LVH, LVH with strain. In differential diagnosis, you will have to differentiate VSD, aortic stenosis, tricuspid regurgitation, hypertrophic cardiomyopathy. As far as etiology is concerned, you will have to differentiate very commonly ischemic heart disease, rheumatic fever, subacute bacterial infective endocarditis, post-surgical floppy mitral valve, etc., which you can easily differentiate by doing a echo, ECG, etc. In an asymptomatic group, regular follow-up is very important, and then you can plan out for mitral valve replacement or a repair. If a person starts becoming symptomatic, then you will require a mitral valve replacement. For an acute MR, you will have to treat with vasodilator, inotropes, and then after a stabilization of a person regarding acute left ventricular failure, you can go for mitral valve repair or mitral valve replacement. Prophylaxis for infective endocarditis should be given. And in a person with left atrial thrombus, anticoagulants to prevent systemic embolization. So diuretics, nitroprusside, nitrates, etc. for acute MR. And if there is myocardial infarction, you might require even cardiac cath followed by thrombolysis. So we say medical stabilization and then followed by other procedures. So medical therapy followed by surgery. In a chronic, usually beta blockers, aspirin for prevention of thrombus formation, infective endocarditis prophylaxis, and depending upon the symptoms, treatment, diuretics, etc. As far as surgical treatment is concerned, two common: mitral valve repair and mitral valve replacement. So these are the medical treatment, and then you can go for mitral valve repair or mitral valve replacement. This is an algorithm which is for chronic severe mitral regurgitation. At your leisure time you can go through. This is again symptomatic chronic MR. What are the algorithms? You can go through at your leisure time. This is chronic severe mitral regurgitation by NYHA groups. This was published by European Society of Cardiology. The algorithm for chronic primary mitral regurgitation. This is repairing of a mitral valve This has to be done with open cardiac surgery. Usually nowadays this is being almost, the days are gone. Mitral valve replacement, again this is open mitral valve replacement, these days are gone. Now there are what are called as closed mitral valve replacement, which is a common procedure. As far as complication is concerned, one of the most common is acute MR, which can end up with acute left ventricular failure. And most common causes of acute MR is infective endocarditis, acute myocardial infarction. These two comes topmost on the list. And then comes what we call as following a mitral valve replacement, post-surgical, due to trauma secondary during left heart catheterization, or even during pacing, CRT, etc. In chronic and mild MR, pulmonary hypertension and right ventricular failure is common. Another complication is infective endocarditis and thromboembolism, atrial flutter fibrillation and thromboembolism. Big enlargement of ALA can produce left bronchus compression leading to hemoptysis and left lung atelectasis. Left recurrent laryngeal nerve palsy leading to hoarseness of voice, also called as Ortner syndrome. Pressure on the esophagus leading to dysphagia. Because of pulmonary congestion, recurrent respiratory tract infection, and you can have sometimes sudden cardiac death. These are some of the complications following in acute MR. MR can progress gradually. You can have a chorda tendini rupture, and you can have an acute MR, or you can have a mild MR. Endocarditis can also produce damage to the mitral valve. TIA are rare, but still they can be there, and very rarely sudden cardiac death. So I end my lecture here. I hope this lecture will be helpful to you. You will come across once in a while this group of people in your everyday